learners, today we are going to discuss about behavioral therapies in substance use disorders. Behavior therapy was introduced by Skinner and Lindsley in a narrow sense related to operant conditioning. However, later Eysenck denoted it as the attempt to alter human behavior and emotion in a beneficial manner according to the laws of modern learning theory. On the basis of several viewpoints, behavior therapy can be defined in various ways. Some behavior therapists view behavior therapy as the application of learning theories, whereas other emphasizes cognitive change. There are also behavior therapists who view behavior therapy as the application of findings from controlled research into clinical treatment procedures. These proponents of the so called experimental clinical approach do not exclusively base themselves on learning theories. Let us see the assumptions in behavior therapy. Nearly all human behavior is learned, we all know that. Disturbances resulting from genetics, biochemical factors and even from lesions can be minimized by behavior therapies. Abnormal behavior is the direct result of maladaptive pattern of behavior or failure to learn adaptive responses, thus resulting in behavioral deficits. Let us see the goals of behavior therapy in substance use disorders. There are three main goals in the primary treatment of substance dependence in context of behavior therapy. First one is there is a need for lifelong abstinence in substance use disorder. This is because of chances of relapse higher in case of substance use because of addictive nature of the substance. There is a need to develop an ongoing recovery program for substance use disorders. Third one is there is a need for better diagnostic strategies and treatment modalities for substance related disorders, comorbidities also, for example, depression, anxiety, personality disorders generally seen in substance use disorders. Now, let us pay a little attention to the origins of behavior therapy, how it emerges. Behaviorism is considered as an important movement in experimental psychology which originated at the start of the 20th century. Although the roots of behavior therapy was laid down by an American psychologist Watson, this therapy became widely accepted much later and did not occur until the 1950s. In 1952, the British psychologist Hans Eysenck caused a major stir with his empirical review claiming that the effect of traditional psychotherapy did not exceed those of no treatment at all. As an effective alternative, Eysenck mentioned behavior therapy based on modern learning theories. Some of the common behavior therapy models which are employed in the clinical setting for substance use are evidence based models focusing on individual cognitive behavior therapy. This was originally designed by treating depression. However, it is effective in treating substance use disorders. It focuses on identification of problem behavior and stimuli for substance use. It helps in developing healthy coping strategies. Another one is contingency management interventions. These interventions utilize reward system for behavior modification and reducing the likelihood of problem behaviors as in the case of substance use. Rewards are usually in form of token, gifts, certificate or clinic privileges, money or vouchers, etc. Generally stars are given in the primary school children. So, motivation enhancement therapy. So, let us see the what is motivation enhancement therapy. This therapy uses motivational interviewing approaches to increase motivation, which is often required in case of behavior modification. This therapy can be used in a range of substance use disorders, including tobacco use to cannabis, alcohol, cocaine, opioids use, etc. Another model is the matrix model. It is an intensive outpatient treatment intervention which is quite effective in stimulant use disorder. This is multi-component intervention. It uses counseling, recovery skills, development, relapse prevention techniques and social support to maintain abstinence. Evidence based models focusing on family therapy. So, family behavior therapy, it involves family members of significant others, impart vocational skills training, communication skills training and training on resisting urges, etc. It also addresses other issues prevalent in the familial settings like conduct disorders in adolescents, etc. Another family therapy is multidimensional family therapy. This is highly used therapy. It is an outpatient treatment program curated for dysfunctional families. It focuses on interpersonal relationship with parents and peers, parenting practices, parent adolescent interaction and improved family communication. Though there are many different forms of behavior therapies, here we are going to discuss mainly three of them, namely cue exposure therapy, aversion therapy and contingency management. Now, we will discuss these therapies one by one. Let us see the cue exposure therapy. In this therapy, clients are exposed to external stimuli related to substance use such as cigarette packet, empty bottle of wine, advertisements, banners, wine shop, etc. and learn to relax and not to use substance during the cue exposure sessions. So, this is carried out to weaken the link between conditioned stimulus and conditioned response. This therapy takes effect by increasing self control in the client with each unreinforced exposure of the stimulus. So, the main goal of this approach is to extinguish learned responses to drug cues which have been learned by the client previously. Here it should be noted that the drug is an unconditioned stimulus and effects of drug are unconditioned responses. Neutral stimuli are visual, auditory, olfactory and tactile attributes of the drug and the different context in which it is taken. For example, the friends or the place where they used to smoke or used to drink. In this therapy, neutral stimulus gets associated with the unconditioned stimulus US and gets converted into conditioned stimuli. So, conditioned stimulus becomes capable of triggering conditioned responses by frequent pairing with the unconditioned stimulus. This form of therapy has been used extensively in alcohol use disorders with promising results. In the preconditioning, image of alcohol produces no response and is neutral stimulus. During the conditioning phase, image of alcohol bottle or alcohol is associated with unconditioned stimulus and produces a favorable response. In post conditioning, only image of alcohol is sufficient to elicit the response. Now, let us see the another therapy which is aversion therapy. So, what is aversion therapy? Where the subject find the substance which he was very liking, now he finds aversive. So, aversion therapy is based on the principles of classical conditioning. So, the conditioning paradigm is used to condition an aversive response to an formally attractive stimulus. Undesirable behavior is paired with aversive stimulus, which causes painful experiences. The stimulus may be an undesirable substance. It is most widely used in the treatment of alcohol dependence. Involves pairing of alcohol with unpleasant symptoms like nausea or vomiting. Conditions aversion to the taste, smell and sight of alcohol are developed. The most common modes of aversion therapy prevalent in clinical settings are electric shock and chemical agents. Let us see the electric aversion therapy. Electrical aversion therapy. This therapy includes administration of slightly painful electrical shocks. Here the aim is reduction of the substance seeking behavior in clients. Electrical stimulus is considered as an aversive consequences of the substance seeking behavior. This therapy is used in self-injurious behaviors, in compulsive sexual behaviors, gambling, paraphilic behaviors, alcohol use and other substances with promising results. There are human rights issues involved in electric aversion therapy, hence it is not used now. So, what happens in aversion therapy? The client has to touch the bottle of alcohol or cigarette packet. As soon as the client touches the bottle, he gets the electric shock. So, this conditioning happens and client generally does not want to use it due to negative consequences. So, as I told you, human rights issues are there. So, this mode is not in use now. So, let us see the other aversion therapy, other type of aversion therapy which uses chemical agents. So, some of the chemical agents used in aversion therapy are agent for alcohol craving, that is for diazepam, naltrexone or acamprosate. So, these are the basically medicines which can be given. So, if diazepam is given in the form of tablet in the morning, if the patient takes alcohol, he may feel nausea, he may feel high blood pressure, there will be heart rate will be more. So, lots of physical symptoms will be there. So, client generally avoid taking alcohol on these medications. So, contingency management. This therapy is derived from the principles of operant conditioning given by B.F. Skinner. Reinforcements and rewards are commonly used to shape the behavior, increase the likelihood of favorable behavioral outcomes. In contingency management, substance use is considered as an operant behavior, which is reinforced by some reinforcers like peer approval, cultural norms, etc. The aim of this therapy is to weaken the effect of reinforcement. The therapist provides positive reinforcement to healthy behaviors for replacing maladaptive one. Healthy behaviors like not taking substance, not smoking. Okay. It may involve monetary based reinforcers or token economy or voucher based treatment, like when the subject is going to clinic, his urine sample is taken and there is no alcohol in the urine, the subject is given a token of suppose a value of 100 rupees or 50 rupees. So, a behavior that is reinforced in close temporal proximity to its occurrence will increase in frequency. If you give a child a small toy or sticker every time he makes his bed, then he is more likely to make his bed next time and its frequency will increase with time. So, you all might have experienced such things. However, there are some drawbacks associated with this therapy. Incentives can be considered kickbacks or inducements when they exceed monetary values that are considered nominal. Let us see the contingency management can be used in cannabis use disorder, stimulant use disorder, cocaine use disorder and stimulant use disorders. There are higher chances of falling back to old maladaptive habits in substance use disorders due to addictive potential and irreplaceable rewards obtained by the substance in the form of varied experiences. This actual return of the pattern of substance use or abuse is known as relapse. However, there is a similar term called lapse, which stands for an initial episode of alcohol or other drug use following a period of abstinence. So, in simpler term, the initial transgression of the problem behavior after a quit attempt is defined as a lapse, which could eventually lead to continued transgression to a level that is similar to before quitting and is defined as relapse. So, in simpler term, like when you restart the substance use, it is lapse, but when you go back to the older pattern of use of the substance, it becomes relapse. The chances of keep continuing to the path of the positive changes, prolapse, is a difficult path, and lapse and relapse are a common part of the treatment process. Hence, relapse prevention therapy, which is based on behavioral and cognitive principles, is found to be useful in substance use disorder. Let us see various concepts of relapse prevention therapy. Lapse and relapse can be determined by following factors. Intrapersonal determinants of relapse. Let us see what are the intrapersonal determinants of relapse. Self-efficacy. So, it is an individual's belief in his capacity to execute his behavior necessary to produce specific performance attainments. In other words, it is the belief that one has the ability to implement the behaviors needed to produce a desired effect. This has emerged as an important predictor and mediator of treatment outcome, especially for tackling problem behaviors in substance use disorders. Another concept is motivation. Motivation is considered as a driving force which initiated, guides and maintains goal oriented behaviors. Motivations and habits of problematic behaviors have been found to be coexisting and intertwined with each other, especially in substance use disorders. So, it can be said that motivation is a key to substance use behavior change, but this has to be noted that motivation to initiate and persist in change fluctuate over time, regardless of the person's stage of readiness in terms of Miller and Rolnick. Another concept is outcome expectancies. Outcome expectancies have been found to be potentially modifiable risk factor for substance use onset. These are the beliefs regarding the positive and negative behavioral, cognitive and emotional effect of a substance. For example, positive substance use expectancies that being under the influence of alcohol would make one feel enjoyment or manage the situation or face the stress. Like if you are in a party with your boss and boss is asking you to have a drink, it will be very difficult for you to say no. Okay, so you may feel stress. So, after some time you may feel that after taking one peg you will be more comfortable with your boss. So, you always think about the positive outcome expectancy. So, negative substance use expectancies, that holding the belief that tobacco use would make one feel sick or cause cancer. So, outcome expectancies have been found to be prevalent in alcohol and marijuana use. It is especially positively linked with onset of these substances. In literature, positive outcome expectancies have been found to be predictor of cognitive distortions and influencing factors of substance use. Let us see the coping. The concept of coping has been tightly linked to the health psychology and is considered to be an important predictor of human behavior under stressful situations. In very simple word, coping means what people do to try to minimize stress. Some of the healthy coping strategies in substance use are avoiding high risk situations which might trigger the substance use and can lead to lapse after abstinence. Now, let us see the regular exercise. So, regular exercise has been linked to increased level of dopamine and serotonin. This elevates mood and helps in overcoming substance use. In treatment setting, it often recommended to exercise for at least 1 hour daily. Avoid halt situation. So, let us see what is halt, HALT. So, H for like remaining hungry for prolonged periods of time, A for feeling angry in most certain or uncertain situation, L for remaining lonely and cut off from the society, and T for tiring situations like pushing oneself to the point of psychological or physical fatigue. So, let us see what are the emotional states. Emotions are psychological states that include subjective, psychological and behavioral elements and associated with thoughts, feelings, behavioral responses and a degree of pleasure and displeasure. Emotions are often intertwined with mood, temperament, personality, dispositions and creativity. Emotions are very strong determinants of one's behavior and thereby are known to influence substance use. Substance use exists hand in hand with negative emotions like depression, anxiety, loneliness and even anger. Craving. Craving is a motivational state for drug seeking behavior. It is a complex process and considered as hallmarks of addiction including nicotine or tobacco and other drugs. It is dynamic neurocognitive emotional motivational response to a wide range of cues from internal and external environment and from drug related to stressful or affective events. Cue induced, that is called phasic craving. So, cue induced craving is thought to result from conditioning processes in which stimuli associated with substance trigger craving and subsequent drug seeking behavior. In contrast, abstinent induced, that is called tonic craving, is thought to develop in the absence of substance related cues, is more sensitive to the delivery of substance and consequently develops quickly after abstinence. So, interpersonal determinants of substance use. Till now we have seen intrapersonal determinants, now we are discussing interpersonal determinants. So, social support network. We all know a social support network is made up of family, peers and friends. The social support obtained by family, peers and friends generally have expressions of empathy, love, trust and caring. This has been shown to be beneficial for abstinence and recovery from substance use disorder. Another one is high risk situations. These are often responsible for falling back to substance use and thereby result in relapse. Some of the high risk situations are negative emotional states, interpersonal conflicts and social pressure. The aim of any therapy dealing with substance use is to help the client developing healthy coping strategies. If patient is unable to cope with the high risk situations, then there is more likely that he or she will relapse. In the presence of effective coping, the probability of relapse decreases. So, let us see the types of relapse. Mental relapse. In mental relapse, there is a war going on inside the patient's mind. Part of them wants to use, but part of them doesn't. As patients go deeper into mental relapse, their cognitive resistance to relapse diminishes and their need for escape increases. Some signs of mental relapse. So, craving for drugs or alcohol, thinking about people, places or things associated with the past use, minimizing consequences or negative consequences of past use of or glamorizing past use, bargaining, okay, I will take only one peg, I won't take more, lying and looking for relapse opportunities like waiting for the parties or the friends to have alcohol and planning a relapse. So, occasional brief thoughts of using are normal in early recovery and are different from mental relapse. So, these are the cravings basically. So, occasional thoughts of using need to be normalized in therapy. They do not mean the individual will relapse or that they are doing a poor job of recovery. Clinicians can distinguish mental relapse from occasional thoughts of using by monitoring a client's behavior longitudinally. Warning signs are when thoughts of using change in character and become more insistent and increase in frequency. Let us see the physical relapse. It occurs when an individual starts using substance again. It can further be divided into a relapse, the initial drink or drug use, and a relapse, a return to uncontrolled using. When clients focus on too strongly on how much they used during a lapse, they do not fully appreciate the consequences of one drink. Once a patient has had one drink, it may quickly lead to a relapse of uncontrolled using of drug, but more importantly, it usually will lead to a mental relapse of obsessive or uncontrolled thinking about using, which eventually can lead to physical relapse. Most physical relapses are relapse of opportunities. They occur when the person has a window in which they feel they will not get caught. Part of relapse prevention involves rehearsing these situations and developing healthy exit strategies. Coming to emotional relapse. Clients remember their last relapse and they do not want to repeat it, but their emotions and behaviors are setting them up for relapse down the road. Because clients are not consciously thinking about using during this stage, denial is a big part of emotional relapse. Some signs of emotional relapses are bottling up emotions, isolating, not going to meetings or missing therapy sessions, going to meeting but not sharing, not involved in the sessions, focusing on others, focusing on other people's problem or focusing on how other people affect them, poor eating and sleeping habits, poor self-care, in which self-care is broadly defined to include emotional, psychological and physical care. Relapse occur in 10 phases. These phases can be differentiated on the basis of phase 1 like internal changes, increased stress, change in thinking, change in feeling, change in behavior. Phase 2 is denial, excessive worrying, denying for any anxiety, denying that they do not have any problem. Phase 3 avoidance and defensiveness, impulsive and compulsive behavior. Phase 4 crisis building, tunnel vision, thinking only about the substance, minor depression, loss of constructive planning, plans begin to fall. Phase 5 immobilization, daydreaming and wishful thinking, loneliness and lethargy. Phase 6 confusion and overreaction. Phase 7 depression. Phase 8 behavioral loss of control. Phase 9 option reduction, there is no other option, only the subject has to take the substance. Phase 10 drug use. So, these are the 10 phases. Now, see the principles of relapse prevention therapy. So, they are self regulation and stabilization, integration and self assessment, understanding lapse and relapse, identification of warning signs, coping skills, change and recovery planning, awareness and inventory planning, help seeking behavior, maintenance of abstinence. To summarize, behavioral therapy is an umbrella term under which a broad range of modalities and techniques are included. They are used for changing maladaptive behaviors like substance use. The basic principle behind behavior therapy is to reinforce desirable behaviors and either reduce maladaptive behavioral outcomes up to non-significant level or eliminate them entirely. It relies on the action based parameters for increasing and likelihood of desirable behaviors. The basic assumption is that old learning is responsible for adoption of some behaviors and coping styles which are maladaptive in nature and generate stress for the individual and his loved ones, including his family members. The mechanism of behavior therapy follows the principles of classical conditioning and operant conditioning. On the basis of classical conditioning, some of the techniques commonly used in behavioral therapies are aversion therapy, flooding, systematic desensitization. On the other hand, contingency management, extinction, behavioral modeling and token economies are some of the techniques used in behavioral therapy, and these are based on the principles of operant conditioning. Behavior therapy has been used extensively to treat many disorders, including substance related disorders. This is often considered as a gold standard in the treatment of alcohol use disorders. So, I thank you for patience listening, and we have discussed today about the behavioral therapies, various behavioral therapies in substance use disorders. Thank you.